Hi, everyone. Good morning. And Dr. Liu, thank you so much for your invitation and your generous introduction. Just to do the Chinese translations, my med school in China was 华西医科大学. So,
Sorry.
That's okay. The title of my talk today is Immune-mediated toxicity of checkpoint inhibitors. As Dr. Liu pointed out, your organization is big into the paradigm shift in healthcare, and checkpoint inhibitor really have provided a huge paradigm shift in cancer treatment, really revolutionized it in the past 10, particularly 5 years. So I'm not a cancer doctor. I don't do cancer treatment. I'm a gastroenterologist. So why am I talking about cancer drugs? The reason is this class of drugs can cause a lot of side effects or toxicities. And the gastroenterology field is one of the most common side effects area. So we often get called upon to do consultation. So what I like to do is to review the literature and starting out with a few cases on my own. But let's talk about what is checkpoint molecules and checkpoint inhibitors. I made this oversimplified illustration. So we have lymphocytes, and some of them are called T lymphocytes, T cells in our body. And one of the functions of T cells is tumor suppression and tumor surveillance. And that's our natural ability to suppress cancer growth and to eliminate cancer in its early stages, but doesn't always work out well. This system is regulated by a group of molecules called checkpoint molecules to make sure that our immune system does not overrun the system and cause autoimmune disease. And so if you make blockers to the checkpoint molecules, which are inhibiting the immune function, you would essentially be making an inhibitor that would be an enhancer, even though the name is called inhibitor, but the drug actually enhances the immune system. So that's what the checkpoint inhibitors are. It turns out it's more complex than that. The checkpoint molecules falls into two groups. One group is stimulatory. It's almost like a gas pedal of the car. You push on the gas pedal, it's going to boost your immune system. But in the meantime, you have on the right panel, you have a group of inhibitory checkpoint molecules. They will put brakes on the system. Between the brakes and gas pedal, you will achieve a regulated immune response to cancer growth inside the body. So back in the 90s, there are some pioneer immunologists who proposed a hypothesis, perhaps if you could inhibit the inhibitory checkpoint molecules, you will unleash the raw power of your own immune system. Maybe you don't need chemotherapy, maybe you don't need radiation therapy, you can get rid of the cancer. Well, it turns out they hit the jackpot. That turned out to be Nobel Prize winning theory. So what they worked on is the three molecules, CTLA-4, PD-1, and PD-L1. And I'll talk more about that. So this translated into drugs that are FDA approved between 2011 and 2018, a total of 7 drugs into 3 categories. One is a CTLA-4, which is cytotoxic T lymphocyte associated antigen 4, and there's only a single drug in that class. The second class is PD-1. PD-1 stands for programmed cell death protein. This protein is a receptor. So a receptor has a ligand, L. So you can either target the receptor or you can target the ligand separately. So you have 3 receptor inhibitors and the 3 ligand inhibitors, total of 7 drugs in this class. All these drugs end with the name in their generic name MAP, monoclonal antibody. So you know these are monoclonal antibody protein drugs. They're huge. You cannot take them by mouth because you're going to digest the protein and turn them into amino acids and destroy the drug. So you have to take them by IV. Well, these names are so confusing. I wanted to talk to you. There's some rules in the nomenclature, but before we talk about that, let's look at the scientific progress made in monoclonal antibody drugs for human uses. As you know, originally monoclonal antibodies made in mice, and it's all fine, wonderful antibody, whether you use that for confocal microscopy, immunoprecipitation, Western blots, or immunohistochemistry. It's in vitro study. It doesn't matter if mouse antibody or rabbit antibody. It works well. But if you're going to make this into a drug and deliver that into human body, the human patient is going to reject the foreign protein from mice. So from the very get-go, the first generation of monoclonal antibody drugs, they made into chimeric proteins. You keep the antigen binding variable region, and then you replace the FB fragment and some of the FAB fragments with human immunoglobulins to make into a chimeric protein. You piece together two different pieces of protein, and that group of monoclonal antibody, first generation, they are named with XI. So like infliximab, rituximab, and abexicimab. So you know that group of monoclonal antibody, when you see that, they were made in the late 90s. They were the first generation monoclonal antibody used for human patients. And then as science progresses, chimeric protein is still not good enough. Perhaps you're generating more anti-drug antibodies, so you made into humanized monoclonal antibodies. You leave very little of the mouse antibody behind, and you use everything else as a human immunoglobulin. And then you progress even more, it's completely human. So it's not even humanized. And so when you make into humanize the drugs, they usually are called a Zumab. So like pembrolizumab, when you see a Zumab, Keytruda, that's a humanized monoclonal antibody. When you see a Mumab or Lumab, then it's completely human. As you go towards the right hand of the monoclonal antibody, you have less likelihood of rejecting the monoclonal antibody drug and making your own antibody. So that's one group of the rules for nomenclature. And then if the drug is directed against the tumor, TU tumor, and you often have a TU in a nomenclature. So rituximab, you look at that, you know it's an anti-tumor monoclonal antibody. If you see a CI, it's a cardiology drug. RealPro was introduced in the late 90s, like Remicade. It's been around forever. I don't think anyone is using that anymore. I haven't seen a cardiologist using that. It's monoclonal antibody raised against the 2B3A glycoprotein, 2B3A of the platelets, and it's anti-platelet drug. And if you see a XLI drug and like ipilimumab, it's an immunotherapy, like a cancer immunotherapy. So that's the nomenclature. If you look at the generic names, you will get an idea whether a cardiology drug, their immunology drug, their tumor drug, and whether first generation, second generation, or third generation monoclonal antibodies. Just a little bit of, when I talk to physicians, I don't show these slides because you're all basic scientists. I wanted to check with you, see if this is how you use it. So like I said, their hypothesis about this immunotherapy turned out to be a huge deal. And the Japanese immunologist who worked on the PD-1 and PD-L1 won the Nobel Prize together with Jim Anderson from initially UC Berkeley. He's the CTOA4 pioneer. Not many people who worked out a monoclonal antibody in clinical medicine have won a Nobel Prize. So this is very special. And if you look at the review article from 2020, there are 7 immunotherapy drugs, and the PD-1 drug, Pempro or Keytruda, has the widest application in terms of FDA-approved indications of cancers. The next one is nivolumab, which is also a PD-1 inhibitor. So it looks like the Japanese approach, the PD-1 and PD-L1, is winning the battle. And the CTOA4 has very limited indication and not any new drugs approved in that class. If you look at this JAMA publication in 2019, which illustrates how immune immunotherapy for cancer has taken off gradually over time. When the first drug, CTLA-4 ipilimumab, was approved by FDA in 2011, no new indication was approved for another 4 years. The initial indication was only for melanoma. So very, very few, 1 to 2% of all cancers are eligible for treatment. And since 2014, more drugs approved and more indications are approved. So by the end of 2018, over 40% of cancers are eligible for immunotherapy. And I'm pretty sure now it's probably more than 50%. What's interesting is the blue line is the number of cancers eligible for immunotherapy. The brown or yellow line is the cancer actually responds to the treatment. You see the two lines does not parallel each other. This one takes off faster than the bottom one. That means the indication is being opened more rapidly. And then, so you're going to see a lot more side effects than therapeutic effect, because some cancers get into treatment because the indication opened up, but they're not going to really respond to the treatment. Well, talking about side effects, this is a Nature review published in 2019, a very nice illustration I borrowed from the chart. The side effects are immune-mediated. It pretty much targets every single system in the body. So whether you're in primary care, you're pulmonologist, nephrologist, neurologist, hematologist, and everyone is going to end up seeing some cases of immunotherapy complications or side effects. And for me, as a gastroenterologist, I deal with hepatitis, pancreatitis, colitis, enteritis, gastro discussion. And next, I'm going to review the literature as scientifically as I can. I know most of you are basic scientists, and that the clinical talks might be a little bit boring to you, but unfortunately, I am a physician, and that's what I do. The first case series, largest case series, came from MD Anderson, and the lead author was Dr. Yinghong Wan, I believe. She's a Chinese physician working as a faculty at MD Anderson. And I'm a big fan of hers because she really pioneered many of the studies, and we followed her publications closely. So she reported about 327 cases of cancer patients that received immune checkpoint inhibitor treatment between 2011 and 2017 at MD Anderson. More than a third of the patients had diarrhea, and 2/3 of the diarrhea patient had to be treated with some kind of immune therapy, immune suppressive therapy, either steroids or infliximab. Infliximab, we talked about, is a chimeric protein against tumor necrosis factor, first introduced in the 90s. We used this drug for treatment of Crohn's disease and ulcerative colitis. So what she showed is that steroids is helpful, but has a higher risk of infection if you use steroids for longer than a month. But if you use the monoclonal antibody infliximab, you will be able to shorten the duration of steroids. You actually lower the risk of infection. Our main concern at the time was tumor necrosis factor inhibitor. Is that safe in cancer patients? Are you going to make the underlying cancer spread like wildfire? Until we saw this publication, we did not feel comfortable giving patients this drug. Actually, this was a very, very helpful landmark study. So what she showed is the overall survival of patients did not differ that much between steroids only and steroids plus infliximab. So infliximab did not seem to have much of a detrimental effect on spreading the cancer. So that gave us confidence to use the drug, which is nice, but that's going to change. Another interesting observation they made was that for survival, they noticed people who developed the side effects of diarrhea. This is a Kaplan-Meier survival curve. The x-axis is time. The y-axis is the drop down of survival. Starting 100% people are alive. As time goes by, people died, and these are the remaining alive person. So you can see people who did not have diarrhea died off much quicker. The people who had diarrhea actually survived the better. Why is that? Well, it makes sense because you're giving somebody immunotherapy. The people who generated stronger immune response would have killed the cancer cells more effectively, and therefore they would survive better. And because they had a stronger immune response, they got its side effects of diarrhea. So the people who develop side effects is not necessarily a bad sign. It's actually a sign of being hopeful. We really, really need to save these people so they can survive their cancer. And so the same group of doctors, Dr. Wan, they published in the same journal, same year, 2018, focused on analyzing the effect of infliximab. It shows infliximab, the monoclonal antibody against the tumor necrosis factor, works faster as compared to corticosteroids like prednisone and solimedrol. So they're really proposing to use this group of drugs. If you use infliximab plus corticosteroids, you can shorten the diarrhea time to be just around 3 days. But if you use steroids and non-prednisone, it's a wide range. It may take 3 weeks, 20-some days to resolve. The median time is 9 days or 3 times longer. So for severe cases, don't hesitate to use biological therapy to control the diarrhea. Around the same time or earlier, different groups tried a different biological therapy. The drug is called vedolizumab. So it's a Zumab drug. You know, it's a complete human monoclonal antibody. The target of this monoclonal antibody is integrin alpha-4 beta-7. As you know, as a basic scientist, integrin is ubiquitous in our body. It's a adhesive molecule, it's calcium-dependent adhesive molecule. As I mentioned earlier, RealPro, the cardiology anti-glycoprotein 2B3A receptor for platelet therapy, is anti-integrin monoclonal antibody. Its target is the platelets, but this integrin alpha-4 and beta-7 is GI tract specific. So this works in the GI tract. What they showed is if you use vedolizumab to treat enterocolitis, it works very well as compared to steroids. We use the fecal calprotectin as the inflammatory marker. Some of you might know what fecal calprotectin is. Calprotectin is a soluble protein from neutrophils. We used to measure clinically fecal leukocytes, measure white cells in a stool to see if somebody got colitis or inflammation, but it's very primitive. Now we measure the soluble protein. 70% of the soluble protein in neutrophil cytosol is calprotectin. And you can quantitatively determine if somebody has inflammation in the GI tract. So the colitis, the normal is less than 200. You can see it goes all the way up to 1800. And if you treat it with vedolizumab or Entyvio, you can bring down the inflammatory marker very, very quickly as compared to steroids. As a matter of fact, Dr. Wan's group at MD Anderson recently just updated their data and presented their data at American College of Gastroenterology annual meeting last October. What they showed is they compared vedolizumab against infliximab, the TNF-alpha inhibitor. People survived better with the vedolizumab treatment arm. So now we're going to be favoring the use of Entyvio or vedolizumab over infliximab, even though the MD Anderson's initial conclusion was that it was not detrimental for survival. But now it looks like it is detrimental to survival to some degree. But I wanted to point out this study is a completely retrospective study, not randomized prospective study. So how well the data will hold over time remains to be seen. But for the time being, we should try to use vedolizumab as much as possible as compared to infliximab. Well, if you're a gastroenterologist, you probably have always run into Crohn's disease or colitis patients that you have what's called the primary failure. You treat the patient, they just don't respond, or secondary failure, you treat them, They responded, and then they don't respond to the drug anymore. Here we go. We have a case published in the New England Journal of Medicine, February this year. As you know, it's very, very difficult to publish any case report in the New England Journal of Medicine. And New England Journal of Medicine has published quite a few checkpoint inhibitor-related case reports in the past 2 years. Fascinating. So this patient was treated with vedolizumab when first started having diarrhea. Patient was hospitalized, had a colonoscopy, treated with steroids and vedolizumab, and you see the diarrhea resolved. It did great. But when the diarrhea came back again a few months later, they treated with vedolizumab, nothing happened. Slight improvement, persisted diarrhea. After 3 doses, it was not doing anything. So they changed to utescolab, which is Stelara, Kinumab. I mean, some tongue twisting problems. So we're using a different biological agent. This is a IO inhibitors, and it works great in this particular patient. So you always need to have a couple of tricks in your sleeves. One thing fails, you have another one to go to. So if Entyvio fails, you can try Stelara. And then what if the biological therapies fail? What else can you do? Well, we have the Janus inhibitor, JAK kinase inhibitor, which is called tofacitinib. And in this case, it's published again in the New England Journal of Medicine as a case report last year. A patient received the Pempro or Keytruda, developed diarrhea, treated initially with prednisone successfully. Prednisone dose was reduced to 10 milligrams. So this side is prednisone dose, this side is diarrhea grade. And the patient diarrhea recurred. They treated it with infliximab, primary failure, did not respond at all. Then they treated with Entyvio or vedolizumab. Patient responded, prednisone dose reduced, diarrhea improved. But while the treatment continued, diarrhea came back again. And so sequentially, they tried the Janus inhibitor and tofacitinib. The patient done well. So it seems to be there's quite a heterogeneous patient population. Some responds to one drug treatment better than other, and we don't know exactly why. What about if all drugs fail, biological or non-biological Janus inhibitor fails, anything else we can do? Well, the hematologists have a few more tricks. They could use extracorporeal photopheresis. So you give the patient a photosynthesizer, circulate the blood outside the body, and you treat it with phototherapy. And what was the ECP used for? It was first used in 1983 for cutaneous T-cell lymphoma, but now it's mostly for bone marrow transplant patients and organ transplant patients. So Fred Hodge at the U would do this kind of therapy. Our community hospitals don't have this. Again, this case was published in the New England Journal of Medicine in January of 2020. Patient failed infliximab, failed glucocorticoids, failed cyclosporine. And when they used ECP, the patient seemed to have responded very nicely. Well, any other tricks? Dr. Wan's group from MD Anderson reported fecal transplantation, and they had 2 patients received fecal donation from a single donor. Both responded well after failing other treatments. So why would fecal transplantation work for immune checkpoint inhibitor side effects? Well, there's some basic science to this. If you look back 1 year prior, in 2017, it was published in the Journal of Oncology. They found the baseline gut microbiota analysis may predict which patient is going to have cancer treatment response and colitis. The two seem to go together. As we talked earlier, you're going to respond to cancer treatment, you're going to get colitis more likely. It turns out if your microbiota at baseline before treatment is mostly the green type of organisms in the Bacteroides phylum, then you're less likely to get colitis and you're less likely to respond to cancer treatment. If your fecal microbiota is predominantly enriched in the red zone, you're going to more likely get colitis and more likely to respond to cancer treatment. The red zones are firmicutes. So there are different anaerobics in the gut. There are 3 different phylums that are dominant there. One's the firmicutes, one's the Bacteroides, and other is actin bacteria. So these 2 seem to play a major role. So my question is, maybe they got lucky. Maybe the donor's baseline microbiota was enriched in Bacteroides. But if you're unlucky, you find a donor who is enriched in firmicutes, and you give this fecal material to the patient who had colitis, you might be adding gasoline to fire. You might make it worse. That's just my theoretical thinking. And because the sample size is so small, it's really hard to draw any conclusions. But I wanted to caution, in private practice, perhaps you want to avoid fecal transplantation to treat this type of patients outside the study protocol for the reason I explained. Well, here's another case report from Johns Hopkins University. Like our second patient, you don't necessarily have bad colitis. You can have horrible diarrhea. So this 80-some-year-old had horrible diarrhea. They did a colonoscopy. It was completely normal. It turns out the abnormality was entirely in the small bowel. So if you're in clinical setting, you got bad diarrhea, infections ruled out, colon's normal, do an EGD, check the duodenum, you'll find enteritis. And you treat enteritis the same way as we treat colitis. Other parts of the GI tract, the upper GI tract, esophagus and gastritis, are less likely to happen, but it does happen. It's being reported. I just wanted to show it here. And there was a case report from Switzerland about refractory esophageal stenosis caused by livolumab. The reason I wanted to show this slide is mainly to point out tocilizumab. So for people following the news in COVID-19, you might have heard tocilizumab. Big deal in COVID-19 treatment, because the Lancet article from Wuhan shows IL-6 elevation in COVID-19 patients is a bad prognostic indicator. People who have very high IL-6 levels, they tend to do poorly. They tend to die more likely in ICU. So this IL-6 receptor inhibitor was used for COVID-19 treatment. It's a small world. Now we're talking about the checkpoint inhibitor side effects using the same drug we used to treat COVID-19. And here's the esophageal stenosis picture. And very, very rarely we see pancreatitis. And here's an interesting case report from Australia. The patient had a pre-existing congenital anomaly. The patient's pancreas is a ring-shaped. It wraps around the duodenal intestine. So every time the patient gets pancreatitis, he developed bowel obstruction, duodenal obstruction. It went so bad, the patient eventually had surgical resection. So here's the duodenal movement. The pancreas was wrapping around it. When checkpoint inhibitor was used, he got pancreatitis and he got recurrent pancreatitis and bowel obstruction. And this is the CT finding of the annular pancreas. The last organ of the GI tract or gastroenterology, hepatology tract is liver. And it's usually not a big deal. They don't go into liver failure, but they behave like autoimmune hepatitis, and you treat it as autoimmune hepatitis, except if you do a biopsy, there are not going to be many plasma cells. When you see an autoimmune hepatitis patient, you mainly see plasma cell infiltration. You know, plasma produces antibody. In the immune checkpoint inhibitor treated patient, it's not the plasma or B cell activation, it's the T cells. they're activated. So that makes sense. You're mostly going to be seeing lymphocytes and not plasma cells. And if you want to know more about GI-related toxicity, there was a expert opinion update published in Gastroenterology in March, just about 3 or 4 months ago. And one of the lead authors is Dr. Wan from MD Anderson. So I've done my job as a gastroenterologist talking about my own specialty, and I'm going to switch hat to talk about other organ systems as an amateur or a general internal medicine physician. If you look at the ASCO guideline, it was initially published in 2018, you'll get a flavor of how these drugs behave differently. The blue bars are CTLA-4, the yellow is PD-1, and the gray is PD-L1. So the side effect profile percentage is very similar between PD-1 and PD-L1, but CTLA-4 is far more potent, and you create a whole lot more side effects. And please note, we talked about the side effects about 30 to 40%, right? GI diarrhea, but why here is only 12, 10%? The reason is this only included high-grade side effects. The lower grade, grade 1 and grade 2 are not included. If you include them all, they will be high up there. But you can see with the CTLA-4, the GI side effect is most common and most severe. So that's why you got a gastroenterologist's attention to evaluate these patients. According to this JAMA update published in 2018, about 30% of patients treated with immune checkpoint inhibitors will develop some degree of dermatology problems. Here, I put together a panel of photos published in JAMA Dermatology just last November. So you have macropapular rashes, you can have bolus, pemphigoid eruptions, looking pretty ugly, and lichenoid eruption, and then you can have psoriasis like silver flaky looking skin rashes. So there are different manifestations in the dermatology world. Some of them can be really, really bad, like this one is called debilitating erosive lichenoid interface dermatitis. It's a mouthful, but looks awful. And look at this patient, got a slice of the scalp whacked off. This is actually not a dermatology disease per se. This is an ischemic tissue necrosis from giant cell arteritis or temporal arteritis. The patient developed headaches, scalp tenderness, jaw claudication, can't chew, and then blurred vision, and then starting skin necrosis after nivolumab treatment for cancer. The next system is endocrinology, which is one of the most common organs to be affected. Thyroid can cause hyper or hypothyroidism. Pituitary, like I said, the Mass General case series shows about 10% of their ipilimumab-treated patients will develop hypopituitary syndrome. And many of them have isolated ACTH deficiency, which will in turn cause secondary adrenal insufficiency. As shown here, the ACTH is low, cortisol level is low. Because if it's primary, the ACTH will be high. So both are no, it's secondary adrenal insufficiency, like our patient number 3, we treated with steroids, and then the hypoglycemia and hyperkalemia resolved. And the next system is neurology. This was published in April 2021 in Neurology. Very nice illustration in terms of frequency of immune-related adverse effects. Encephalitis, 13%, neuropathy, 22% of patients will develop that, and the most common is myositis. And myasthenia gravis can happen as well. But in terms of fatality, if you rank them, the most likely to die is myasthenia gravis, 重症肌无力, and encephalitis, 老炎, and myositis, muscle inflammation. If you get meningitis, the likelihood of dying is pretty rare. Here is a case report from Portugal. A patient received ipilimumab and then got rash, pruritus, which is not uncommon. 30-some% would develop skin problems. And then the patient developed shortness of breath and a muscle weakness and diplopia. Diplopia meaning double vision. What is this? Well, he's got the myasthenia gravis 重症肌无力. People die from this because their respiratory muscle would lose strength. They can't breathe and they will die. And then here's another neurological complication. The patient developed quadriplegia. What is quadriplegia? 四肢瘫痪. You know, you have paraplegia, hemiparesis, and this is quadriplegia, meaning all extremities paralyzed. What happened? This patient had metastatic melanoma, had a combination therapy of ipilimumab and nivolumab, progressively got muscle weakness, and the lab shows the potassium was barely detectable, very acidotic. It turns out they finally determined this patient developed type 1 RTA, which stands for renal tubular acidosis, 肾小管酸中毒. There are different types. Type 1 and 3 causes very low potassium, and type 4 causes high potassium. So this patient developed RTA and extremely low potassium, which caused him to be paralyzed. So you can see some of these side effects can be really, really critically ill and fatal, and the mechanism is different. So that's a neurological system. What about the hematological system? You can see hemolytic anemia, ITP, idiopathic thrombocytopenia purpura, and the hematologists will manage this themselves, so they don't need our consult. And here's an interesting report about TTP, thrombocytopenic purpura. And this disease is a hematological emergency, and they die from this. So you have the blue bar, which is creatinine. Normal is less than 1, is rising to 3. So you got acute kidney failure. The red one is LDH, is lactate dehydrogenase. Enzyme went up really high. Why? Because the patient has hemolysis. This is an intracellular enzyme. When the cells die, they release massive amount of LDH. And then the green bar is hemoglobin. Normal is 12 and above. This one is only 6, but half what's normal. Why? Because the red cells lysed, hemolyzed, and that's why they became anemic. And then the purple line is platelets. Normal is over 150,000, and this patient's platelets from the beginning was barely detectable. So if you don't identify this promptly, and patient really dies with high mortality. So the patient received the standard treatment. As you can see, everything recovered accordingly. What about pneumonitis? We talked about our second patient before she died. The chest X-ray showed bilateral pneumonia. Is a pneumonitis. It's infection pneumonia. We didn't know, but pneumonitis, non-infectious pneumonia, is not very common, about 5%, but can be very fatal. Usually it's about 5%. The treatment is very similar, but I wanted to point out there was a very novel treatment for this condition. Again, it was published as a case report in the New England Journal of Medicine last June. It's amazing how many case reports have been published in the New England Journal of Medicine for this topic. They used inhaled vasoactive polypeptide. And we're, as gastroenterologists, are very familiar with VIP. Some have massive diarrhea. They could have VIPoma from the pancreas. It causes secretory diarrhea like cholera. So in this patient, they treated with a standard treatment, and then they added inhaled VIP. And you can see this group of pneumonia infiltrates in the CAT scan resolved or improved significantly after treatment. Why would the drug do it? Nobody knows. But this drug has been previously used to treat the sarcoidosis of the lungs. So for that precedence, they tried this drug for this purpose, and it seemed to have worked. So if you're a pulmonologist, or you happen to have a severe tough case of checkpoint inhibitor pneumonitis, you might want to consider adding this inhaled vasoactive peptide. Well, last but not least is the cardiovascular system, which is fatal. And this article was published by the European Society of Cardiology in 2019. But if you look at the contributing authors, many of them are from the US, like Vanderbilt University, Johns Hopkins University, UCLA, and the Brigham Women at Harvard. But it's a group of international contributors that compiled the data. Myocarditis can happen. Pericarditis, the membrane wrapping around the heart, can be inflamed. Vasculitis, and we talked about temporal arteritis, right? Giant cell arteritis that caused scalp necrosis, whacked off a big piece of skin on the patient's head. These all being reported. And usually temporal arteritis occurs as a part of PMR, polymyalgia rheumatica, and these patients needs to be identified, treated very, very promptly to avoid bad outcome. Let's focus a little bit more about the myocarditis. So this occurs in about 1% of all checkpoint inhibitor treated patients, but if it happens, the mortality is typically about 50%. Very, very bad outcome. And for the mild cases, and they tend to have AV blocked, so there will be PR interval prolongation on EKG, or of course you can see ventricular tachycardia. But if you do a biopsy of the myocardium of the heart, you see a lot of lymphocytic infiltration. If you do immunohistochemistry staining, they're mostly T cells, CD3 positive, CD8 positive T cell infiltration. We talked about T cell, not plasma cell, not B cell is the problem with the checkpoint inhibitor treated patients. And here is a case series of 5 patients. They were able to use MRI, cardiac MRI, to early identify without myocardium biopsy the myocardium edema. And by T2 images will have a very high density, whiteout density to suggest the heart muscle is inflamed and swollen. And this can be a fairly reliable, non-invasive diagnostic approach. How do you treat it? And again, another case report published in the New England Journal of Medicine on this topic. In this group, I believe it was a Canadian group, they used a monoclonal antibody that used to be used for treatment of T-cell lymphoma. You see the nomenclature, it's a zoom map, so we know it's a human monoclonal antibody. It got a TU, so we know this monoclonal antibody is used for tumors treatment. So alemtuzumab. And they did a beautiful flow cytometry study from day 1 to day 50. They did interval flow cytometry to map out the cell composition in the blood. So keep your attention to the pink pie. This refers to T cells. As we pointed out, this is a T cell disease. And at baseline, after myocarditis occurrence, they gave the patient immunotherapy by steroids, mycophenolate, which is immunotherapy, and rituximab for immune suppression. For 18 days, the T cell population shrunk a little bit, but not by much, and the patient did not improve adequately. And on day 18, they gave this T cell lymphoma tumor monoclonal antibody, alemtuzumab. And within the 10 days, the T cell population became barely detectable, shrunk almost completely. And corresponding to that, the patient's myocarditis improved dramatically. So this was a huge success. But whether this can be reproduced in other patients remains to be seen, because this is simply a case report. It's so new, everything's changing. So as you follow this field, every time you do a literature search, you'll find something new. To not to bore you anymore, I'm tired of talking. I'm pretty sure you're tired of listening to me, particularly if you're a basic scientist. I will use this illustration from a recent publication that shows the time course of different side effects. You use CTLA-4 inhibitor treatment, Your most severe and most likely side effects or toxicity is this yellow line, which is colitis. The GI tract is most commonly involved, most severely involved, and it happens early, about 5 weeks or so. The next one commonly occurring early on is skin. Dermatologists will see them, but since they're mild, they probably don't end up going to the dermatologist that much. The green one is liver toxicity. So this is liver toxicity. As you can see, whatever goes up must come down because this is temporary rise of immune intensity, except the blue line goes up and never comes down. What is blue line? Endocrine. So if you destroy the endocrine organs like a thyroid, pituitary, you're going to have to need permanent replacement therapy. And if you do the PD-1 and PD-L1 inhibitor treatment, these treatments tend to be maintenance therapy. Unlike the CTLA-4, you give 4 doses, you're done. And these people may be on months and years. So you have some later complications that you don't see with this drug. What's the later complications? The pneumonitis that typically occurs after 3 months of treatment, the purple line. And the other one is nephritis. And that happens much later. Our patient, renal tubular acidosis, also happened after prolonged treatment. If you use combination therapy, it's kind of all over the map. To summarize how ASCO, how you treat this group of patients, I use an earlier guideline published by ASCO in 2018. It grades the side effects from grade 1 to grade 5. Grade 5 is death. You don't treat them anymore because you lost your patients. And the grade 1 is minimum. You can continue the drug and you can do some treatment. And grade 2 to 4 are the most likely patients you're going to run into. You suspend their treatment, you treat them, or sometimes permanently stop the drug if some fatal complications have happened. As the guidelines are being, as literature come out more, the guidelines are being updated constantly. So this is NCCN guideline published in 2020. I'm pretty sure they're going to have another version coming up later this year. I just wanted to point out the literature is widely available, perhaps too much information, but it's there. If you need to look into the details, you have access to these references. Well, thank you very much for joining me for this very interesting field in medicine that revolutionized the cancer treatment, but also generated a whole new group of diseases that we clinicians have never seen. So I thought when Dr. New invited me to give a talk, I couldn't come up with any topic that could be related to the basic scientists in biological research. I thought this topic will involve so many biological drugs, and you might be interested, and hopefully I did not bore you out. Thank you.